Welcome to the deep dive. Today we're getting into something really key in medicine, cephalosporin antibiotics.
That's right.
We've pulled together quite a bit of info, and really our mission here is to boil it down for you, give you a clear picture of these really vital drugs. What they actually are, how they work against infections, and why these different types, these generations, really matter in, well, the fight against bacteria.
Exactly. Think of this as your guide to understanding a major player in infection treatment. We'll walk through the different generations, see what bacteria they're good against,
Okay.
and look at how these drugs have gotten, well, smarter over time.
Okay, so let's start right at the beginning. What are cephalosporins, fundamentally?
Well, fundamentally, they're a type of beta-lactam antibiotic, so they're related to penicillins.
Oh, man.
They first came onto the scene back in the 1960s, another tool in the toolkit against bacteria.
Gotcha. And how do they actually work? What do they do to the bacteria?
Their main job, really, is to mess with the bacteria's ability to build their cell walls.
The walls, like defenses.
Exactly. Think of it like a fortress wall. Cephalosporins interfere with making peptidoglycans. These are like essential bricks for that wall, especially when the bacteria are dividing.
Ah, when they're vulnerable.
Right. And without that strong wall, the bacteria just can't handle their internal pressure. Osmotic pressure builds up and pop, they burst.
Wow.
And what's interesting is, depending on the exact drug and the dose, they can be bactericidal, meaning they kill the bacteria directly, or sometimes bacteriostatic, just stopping them from multiplying.
That's a great image, dismantling the fortress. So when do doctors typically use them? What kinds of infections?
Oh, they're used for a whole range of infections caused by bacteria that they work against. And this is really key. Ideally, before starting treatment, you want a culture and sensitivity test.
Right, to know what you're fighting.
Precisely. It finds the specific bug causing the trouble and tells you which antibiotic is most likely to knock it out. It's about using the right key for the right lock, you know?
Makes perfect sense.
Yeah.
The smart approach. Now, you mentioned generations. Sounds like these drugs have, well, evolved. What's the story there?
That's exactly it. Bacteria are pretty clever. They develop resistance, so scientists have had to keep developing newer versions of cephalosporins.
Keeping one step ahead, hopefully.
Trying to. And these versions are grouped into generations. Each generation usually has a different spectrum of activity.
The spectrum of activity, meaning?
Meaning the range of different bacteria that a specific antibiotic can effectively target. Each new generation tends to broaden that range or sometimes shift it.
Okay, so let's walk through them. The first ones, the original models, what did they go after?
So the first generation drugs are mainly good against gram-positive bacteria, a lot like early penicillin in that respect. And they also hit a specific group of gram-negatives, Proteus mirabilis, E. coli, and Klebsiella pneumonia. There's a little mnemonic people use, PECK, P-E-C-K. Helps you remember those three.
Peck, okay, like they're pecking away at those specific ones.
Sort of. Think of them as the first line against those particular threats.
And what are some common names? Drugs people might recognize?
Yeah, you'll see cefazolin that's often used before surgery to prevent infections.
Prophylactically.
Exactly. And then there's cefadroxil and cephalexin. Cephalexin is probably better known as Keflex, often used for skin infections, that sort of thing.
Keflex, right. Okay, so first gen covers PEC. What did the second generation add? What new bacteria could they handle?
The second generation expanded the coverage. They still got the PEC bacteria, but they also became effective against Haemophilus influenza, Enterobacter aerogenes, and Neisseria species.
Okay, more targets.
Right. So the mnemonic gets a bit longer. ENPEC, H-E-N-P-C-K. They were designed to tackle a slightly broader set of common infections.
ENPEC. Adding H, E, and N. Was there a downside? Did they lose ground anywhere?
That's a good question. Generally, yeah, the second-gen drugs can be a little less potent against some of the gram-positives that the first generation handled really well.
So a trade-off.
Often, yeah. It's kind of a balancing act when you're trying to broaden the spectrum.
Interesting. So it's not just more is always better.
No.
And what are some examples of these second-gen drugs?
Well, there's Cefaclor, brand name Secler often. It comes in doses for adults and kids.
Right.
Used for respiratory infections, skin issues, UTIs, ear infections, even things like typhoid fever or anthrax exposure in some cases.
Wow, quite versatile.
Yeah. And others include cefotatin, cefoxitin, cefprozil, and ceftriaxone. Sometimes you see that as Zinacef.
Okay. So we went from PEC to HENPEC, logically third generation.
Yeah.
What's next?
Third generation broadened things even further.
Yeah.
Still active against the henpeck group,
Mm-hmm.
but they added Serratia marcescens. So now the mnemonic is henimpex, adding the S.
Henpeck S. Okay.
And a key thing here is, while their activity against some gram-positives might be a bit lower than the earlier ones,
Right, the trade-off again.
yeah, they became much more effective against a wider range of gram-negative bacilli. And those can cause some pretty serious, complicated infections.
So they're really widening the net against those tougher gram-negatives now.
Yeah.
Who are the big players in this third generation?
You might hear of cefdinir, that's Omnicef, cefotaxime or cloforin, cepodoximate, ceftazidime, that's Ceptaz or Tazicef, and a really common one is ceftriaxone or Rosifin.
Rosifin, yeah, I hear that one a lot.
It's widely used, and interestingly, ceftriaxone is a bit different in how it leaves the body.
Oh, how so?
Most cephalosporins are cleared out mainly by the kidneys, but ceftriaxone, primarily handled by the liver.
Huh. That could be important depending on the patient, I guess.
Definitely, especially if someone has kidney issues, for example.
Good point. Okay, so now fourth generation and beyond, where did things go from there?
So the main fourth generation one is cefepime, brand name Maxicime. This was really a move towards even broader, more potent spectrum.
Broader still.
Yeah, it hits a wide range of both gram-negatives and gram-positives. And crucially, it includes Pseudomonas aeruginosa.
Ah, Pseudomonas. That one's notoriously tough. Right?
Exactly. It can be really difficult to treat. So having cefepime was a big step.
And beyond. What else is new?
Well, beyond the fourth gen, we started seeing combinations. Cephalosporins paired with something called a beta-lactamase inhibitor.
Beta-lactamase inhibitor. What does that do?
So bacteria fight back, right?
Yeah.
One way is by producing enzymes, beta-lactamases, that break down beta-lactam antibiotics like cephalosporins.
Ah, they disable the weapon.
Exactly. So these inhibitors, like tazobactam or avibactam, basically block those bacterial enzymes. They protect the cephalosporin so it can still do its job.
Like giving the antibiotic a bodyguard.
That's a great way to put it. Examples are ceftazidime tazobactam, which is Zerbaxa, and ceftazidime avibactam, or Avicaz. These are really important for tackling resistant bacteria.
That seems critical given how resistance is spreading.
It absolutely is. And there are others, too. There's ceftaroline, or Teflaro. It's notable because it works against some MRSA strains, methicillin-resistant Staph aureus.
Wow, MRSA coverage. That's significant.
Yeah, it's used for things like community-acquired pneumonia and certain skin infections. And even more recently, there's cefiderocol, Fatroja.
Sure.
That one targets complicated UTIs and serious hospital-acquired pneumonias. It's like a continuous innovation cycle.
Definitely sounds like an arms race against the bacteria.
Yeah.
Looking back across all these generations, are there any, general trends we can spot?
Yeah, a few patterns emerge. As you go up in generation number, say from first to fourth, the drugs generally get better at crossing into the cerebrospinal fluid. That's important for brain or spinal cord infections, meningitis, for instance.
Okay, better penetration.
Right. They also tend to be less susceptible to being destroyed by those bacterial beta-lactamase enzymes we talked about.
Oh, it's stable.
More stable against those specific defenses, yes. And as we've seen, their effectiveness against gram-negative bacteria generally increases with each generation.
That's a really helpful summary. So, okay, we have all these different types. What are the really crucial things clinicians, and maybe even patients, need to think about when these drugs are actually used?
Right. Practical considerations. First off, pharmacokinetics, how the drug moves through the body. Like we touched on, most are primarily eliminated by the kidneys, unchanged in the urine.
So kidney function matters.
It's a lot.
Hugely. If someone's kidneys aren't working well, the drug can build up, potentially reach toxic levels. So doses often need to be lowered.
Except for ceftriaxone.
Exactly, the exception. Since it's mainly cleared by the liver, kidney function isn't as critical for its dosing, though you still have to be mindful.
Okay. What else in pharmacokinetics?
They do cross the placenta during pregnancy, and they can get into breast milk.
So caution needed there. Definitely. It's always a risk-benefit calculation. Use only if the potential benefit justifies the potential risk to the fetus or infant.
Makes sense. What about situations where you absolutely shouldn't use them or need to be extra careful? Contraindications?
Yeah, absolutely vital. The big one is allergy. If someone's had a severe allergic reaction like anaphylaxis to a cephalosporin before, you generally avoid the whole class.
And the penicillin connection.
Right. There's a known potential for cross-reactivity. Someone allergic to penicillin might also react to a cephalosporin. It's not guaranteed, the risk varies, but you need to be cautious.
Okay. What else?
Liver or kidney problems, as we discussed, need careful monitoring and potential dose adjustments because these drugs can be tough on the kidneys, and poor function affects how the drug is handled.
Right. And pregnancy, lactation we covered.
Yep. Always weigh the pros and cons carefully there.
So let's talk side effects. What might someone actually experience?
Well, the most common things are GI related. Gastrointestinal.
Like upset stomach.
Exactly. Nausea, vomiting, diarrhea, maybe loss of appetite, some abdominal pain, gas, that kind of stuff.
Fairly standard antibiotic stuff sometimes.
Often, yes. But there's a more serious, though less common, GI issue called pseudomembranous colitis.
Oh, I've heard of that. C. diff related.
Often caused by Clostridioides difficile. Yeah. It happens when the antibiotic wipes out too much of the normal gut bacteria, allowing C. diff to overgrow. Causes severe diarrhea, fever, bad abdominal pain.
So if that happens, call the doctor immediately.
Absolutely. It needs prompt treatment. Other possible side effects. Maybe headache, dizziness, feeling lethargic, sometimes tingling sensations, paresthesias.
Okay.
And there's that risk of nephrotoxicity, kidney damage, particularly if someone already has kidney issues. You can also get superinfections. Similar to C. diff, disrupting the normal flora allows other things like yeast to overgrow.
Right, secondary infection.
Yeah. And if you're getting it IV, you might get phlebitis inflammation at the vein site or an abscess if it's an intramuscular shot.
Okay, good to be aware of. What about interactions? Do they play well with other medications?
There are a couple of important ones to watch out for. If used with aminoglycosides, another class of antibiotics.
Like gentamicin.
Exactly, like gentamicin. The combination increases the risk of kidney damage. So if they have to be used together, you monitor kidney function really closely, BUN and creatinine levels.
Anything else?
Warfarin, the blood thinner.
Oh, what happens there?
Cephalosporins can potentially increase the anticoagulant effect of warfarin, raising the risk of bleeding.
So more monitoring needed for bleeding.
Yes, definitely. Careful monitoring, and the warfarin dose might need adjusting.
Okay. We mentioned it a few times, but let's really underscore this antibiotic resistance issue. How big a problem is it with cephalosporins?
It's a huge problem, a major global health threat. And unfortunately, yes, bacteria are increasingly developing resistance to cephalosporins.
Meaning the drugs just don't work as well.
Or sometimes not at all against certain strains. This makes infections much harder, sometimes impossible, to treat with standard options.
And that's why those culture and sensitivity tests are so important.
Absolutely crucial to make sure the drug you're choosing actually will work. And it's why we need good antibiotic stewardship, using these drugs only when necessary, using the right drug at the right dose, for the right duration.
So reserving them for appropriate situations.
Exactly. Overusing them or using them incorrectly just speeds up the development and spread of resistance, which ultimately harms everyone.
It really puts the responsibility on both prescribers and patients.
It does.
So thinking about healthcare teams, like nurses on the front lines, what are they focusing on when a patient is on a cephalosporin? Obviously useful for all of us to know, but what's their specific lens?
Nurses play a really critical role. First, that thorough assessment, asking about allergies, penicillin, cephalosporins, checking kidney function history, pregnancy, breastfeeding status, all that background.
Due diligence.
Absolutely. Then, vigilant monitoring for any adverse effects is the patient having bad diarrhea, dizziness, any skin reactions, trouble breathing.
Catching problems early.
Exactly. And patient education is huge, making sure the patient understands they must take the full course, even if they feel better after a few days.
Right. Stopping early breeds resistance.
Precisely. Plus, providing comfort measures for those common side effects, like suggesting how to manage nausea or diarrhea, and teaching patients what signs mean they need to call the doctor right away.
That holistic patient care aspect.
Very much so.
Okay, so if we were to wrap this all up, what are the main things you want people to take away from our deep dive today?
I think the key things are cephalosporins are a really valuable, diverse group of antibiotics, these beta-lactams. The different generations offer different strengths against different bacteria, but using them wisely is critical. We have to consider the potential side effects, those drug interactions, and always, always be mindful of the massive threat of antibiotic resistance.
And maybe most importantly for the listener, always follow your doctor's advice and finish the entire course of antibiotics if you prescribe them.
Couldn't have said it better myself. That is absolutely fundamental for effective treatment and for protecting these precious resources for the future.
So here's something to chew on as we finish up. We see this constant development, new cephalosporins, those beta-lactamase inhibitor combos. What do you think the future landscape of antibiotic treatment looks like? And maybe more importantly, how can we, all of us, globally, best protect the effectiveness of the antibiotics we still have?